Thank you, everybody. We're going to go ahead and get started. As we open and start with today's session on COVID-19 vaccines, I'm going to actually first turn it over to Dr. Melinda Wharton for an announcement.
Thank you, Dr. Lee. I wanted to call on our colleague from the Food and Drug Administration, Dr. Rebecca Rendell, for an announcement about some recent FDA regulatory action.
Hi, good morning, everyone. This is Becca Reindell. This morning, the FDA authorized the Novavax COVID-19 vaccine adjuvanted for use under EUA as a first booster dose to individuals 18 years of age and older, for whom an FDA-authorized mRNA bivalent COVID-19 booster vaccine is not accessible or clinically appropriate, and to individuals 18 years of age and older who elect to receive the Novavax COVID-19 vaccine adjuvanted because they would otherwise not receive a booster dose of COVID-19 vaccine. For these individuals, a booster dose may be administered at least 6 months after completion of a primary vaccination with an authorized or approved COVID-19 vaccine.
Thank you. Dr. Twentyman?
Thank you so much. As a further update, Centers for Disease Control and Prevention has signed off on recommending use of the Novavax monovalent COVID-19 vaccine as a single booster dose in those ages 18 and above, as outlined in the authorization from the Food and Drug Administration.
Sorry.
Following these recommendations, you will see our interim clinical considerations for use of authorized and approved COVID-19 vaccines updated, along with all accompanying schedules and clinical guidance materials. Thanks very much. Over to you, Dr. Daly.
Okay, Matt Daly here. I'm just waiting for my slides to come up. Okay, great. Thanks so much. So I'm going to be introducing this afternoon's session on behalf of the ACIP COVID-19 vaccines work group. Next slide, please. To provide several updates to start with, bivalent booster authorizations have been extended down to children ages 5 years and over. So on October 12th of 2022, the FDA granted emergency use authorization for the use of Moderna bivalent COVID-19 vaccine boosters in children ages 6 through 17 years. On that same day, there was also emergency use authorization for the use of Pfizer-BioNTech bivalent COVID-19 vaccine boosters in children ages 5 through 11 years of age. And then on that same day, the CDC signed off on those recommendations and endorsed those for the exact same groups and ages. Next slide, please. So, excuse me, to review COVID-19 vaccines workgroup activities for the months of September and October of 2022, we have reviewed and discussed the vaccine safety and immunogenicity data for monovalent Moderna COVID-19 vaccine boosters for children ages 6 through 17 years of age. We also reviewed vaccine safety and immunogenicity data for the Novavax COVID-19 vaccine booster for adults ages 18 and over. In addition, we reviewed and discussed COVID-19 epidemiology and outcomes among people who are pregnant, as well as COVID-19 epidemiology and outcomes among infants. In addition, we looked at vaccine safety and effectiveness data pertaining to the use of COVID-19 vaccines during pregnancy. And then we also discussed the proposed integration of COVID-19 vaccines into the Vaccines for Children, or VFC, program. Next slide, please. So the agenda for this session this afternoon is as follows. First, we'll hear from Dr. Ellington at the CDC, who's going to review COVID-19 in pregnant people and infants ages 0 to 5 months. We'll then hear data regarding vaccine safety during pregnancy from both Dr. Olson at the CDC and Dr. Carbonda from Health Partners. We will hear about the effectiveness of maternal COVID-19 vaccination in pregnant people and infants from Dr. Fleming Dutra from the CDC. Following that, we'll hear from Dr. Oliver at the CDC, who will review a summary of the evidence around COVID-19 vaccine use in children. And then we will hear from Dr. Santoli, who will review the implications for the Vaccines for Children program. There will then be public comment, following which there will be a COVID-19 vote that is specific to the inclusion of COVID-19 vaccines in the VFC program. Next slide, please. And then I'd like to thank the ACIP COVID-19 vaccines work group, including ACIP members, ex officio and government members, liaisons, consultants, and the excellent CDC leadership of Dr. Oliver and Dr. Twentyman. Next slide, please. As well as a number of CDC participants in the COVID vaccine work. Back to you, Dr. Lee.
Thank you, Dr. Daly. We'll move on to the next presentation by Dr. Ellington from CDC.
If we could move to the next slide. And the next slide. So first I will provide a brief background on what we know about COVID-19 in pregnant people. Next slide. When we assess risks in pregnancy for new threats, we typically think about this in three ways. First, we assess if the state of being pregnant is associated with severe illness. For this, we typically compare pregnant people to a non-pregnant group, usually women of reproductive age. Second, we assess if pregnant people with COVID-19 have increased risk for maternal complications and adverse pregnancy outcomes compared to pregnant people without disease. And third, we assess if infants born to people with COVID-19 during pregnancy are at risk for severe outcomes. Next slide. A recent updated living systematic review and meta-analysis by colleagues in the UK assesses pregnancy as a risk factor for severe illness, so comparing people with COVID-19 by pregnancy status. Among all the outcomes examined, the odds of ICU admission and invasive ventilation were increased in pregnant people compared to non-pregnant women of reproductive age. An important consideration, though, is that the meta-analysis does not adjust for potential confounders, so likely underestimates the risks, as we have observed in our US data that pregnant women and people with COVID-19 are younger and have less underlying health conditions than non-pregnant people with COVID-19. Next slide. We closely monitored cases of COVID-19 in pregnancy using CDC's national case surveillance data, which includes a pregnancy variable from June 2020 to July of 2022. In this graph, the total cases are represented by the gray line. ICU admissions by month are in lighter blue, with deaths by month in dark blue. In total, 226,263 infections in pregnant people were reported as of July of this year. Case counts peaked in December of 2021 and January of 2022. There were 738 ICU admissions reported among pregnant people and 329 deaths. ICU admissions and deaths both peaked in August 2021 when Delta was the predominant variant. Next slide. So now I'm going to talk about the second and third questions to assess risks of maternal, fetal, and infant adverse outcomes among pregnant people with COVID-19 compared to those without COVID-19. These data are again from the same living systematic review and meta-analysis in the previous slide. All maternal and perinatal outcomes assessed were significantly higher in pregnant people. The odds of all-cause mortality was 6 times as high for pregnant people with COVID-19, and ICU admission was 5.4 times as high. There was a 57% increase in the odds of preterm birth and an 81% increase in the odds of stillbirth. Additionally, the odds of neonatal death and admission to the neonatal intensive care unit were more than twice as high for infants born to pregnant people with COVID-19 during pregnancy than those both to pregnant people without COVID-19. Next slide. These are data from the Surveillance for Emerging Threats to Mothers and Babies network, assessing outcomes among pregnant people with COVID-19 during pregnancy. And this demonstrates that the risks also vary by trimester of infection, with the third trimester infections associated with the greatest risks of preterm birth, neonatal ICU admission, and infants being born small for gestational age. Next slide. So now I'll briefly present COVID-19 vaccination coverage among pregnant people and where we currently stand. Next slide. Here are COVID-19 vaccine coverage estimates in pregnancy from 2 data sources. The percentage that completed a primary series is in blue, and among those that received the primary series, the percentage that have received a monovalent booster is in green. The National Immunization Survey is self-reported survey data, and this is data from the last month, estimating that 77% of pregnant people received a primary series. And of those receiving a primary series, 48% received a first booster. These data are weighted to be nationally representative. The second data source here is from Vaccine Safety Data Link, which uses electronic health data from 9 healthcare organizations and found that 72% of pregnant people had received a primary series, with 60% of those receiving a booster. Overwhelmingly, most pregnant people received the primary series before they became pregnant. Also, the vaccine safety data, from there, you can calculate that 43% of pregnant people received both their primary series and their monovalent booster, indicating that more than half of the population of pregnant people are likely unvaccinated or undervaccinated currently. Next slide. Now I will pivot to talking about the epidemiology of COVID-19 among infants from birth up through 5 months. Next slide. This graph shows COVID-19 associated hospitalization rates from CDC's COVID-Net surveillance system in persons of all ages from the start of the pandemic in the US through September 10th, 2022. The shaded regions on the graph represent the different periods of SARS-CoV-2 variant predominance, from the Delta period to the Omicron BA.5 period. The focus here is on infants ages 0 through 5 months, shown in red, but other age groups are shown for comparison. Throughout the pandemic, rates in adults ages 65 years and older, shown in the blue dotted line, have been highest. And we know that older adults are at highest risk of severe disease with COVID-19. However, notice that in the Omicron periods, rates among infants ages 0 through 5 months have increased relative to other age groups. They have surpassed rates in those 50 to 64 years of age, shown in yellow, and they are now approaching the rates of those 65 years and older. Next slide. Here is a comparison of hospitalization burden for COVID-19 and influenza, which has long been recognized to cause severe respiratory disease in infants ages 0 through 5 months. During October 2020 to September 2021, the cumulative COVID-19 associated hospitalization rate shown in the black line was similar to influenza associated hospitalization rates during the pre-pandemic influenza seasons from 2017 through 2020, shown in gray. During October 2021 to April 2022, the preliminary cumulative COVID-19 associated hospitalization rate, shown in red, was higher than influenza-associated hospitalization rates during the same pre-pandemic influenza seasons. These data indicate that COVID-19 can cause a similar higher burden of hospitalization as influenza in infants ages 0 through 5 months. Next slide. Additionally, among infants ages 0 to 5 months with COVID-19 associated hospitalizations, 84% of infants had COVID-19 symptoms, including 97% of those greater than 1 month of age. 21% had an underlying health condition with prematurity most frequent. 19% were admitted to the ICU. When we look at disparities in this age group, we see that the cumulative COVID-19 associated hospitalization rates are highest in infants ages 0 through 5 months who are non-Hispanic American Indian and Alaska Native, Hispanic, and non-Hispanic Black. As we know, COVID-19 has exposed long-standing inequities that have systematically undermined the health of racial and ethnic minority populations, putting them at higher risk for infection, severe illness, and death. Unfortunately, these disparities also affect infants. Tragically, COVID-19 has caused deaths among infants ages 0 through 5 months. According to death certificate data from January 2020 through October of 2022, 265 deaths due to COVID-19 have been reported, accounting for 0.5% of all deaths in this age group. Next slide. I'll now hand it over to Drs. Olson and Carbanda to talk about safety.
Thank you very much. This is Dr. Carbanda. I'm going to go first. And next slide. And next slide. So as an overview for this presentation from the Vaccine Safety Data Link, I will present analyses of spontaneous abortion case and ongoing pregnancy control surveillance following COVID-19 booster vaccination. And I will provide a summary of VSD studies on COVID-19 vaccine safety and pregnancy. Then Dr. Olson will present data from the VSafe COVID-19 Vaccine Pregnancy Registry, including describing the registry participant cohort and presenting preliminary data on pregnancy and infant outcomes. Next slide. This slide shows a map of the VSD sites with locations as of August 2022. 8 VSD sites contributed data for the analyses I am presenting. Next slide. For our case control surveillance, our primary objective was to conduct monthly surveillance of spontaneous abortion cases and ongoing pregnancy controls in order to estimate the odds ratio for receiving a third messenger RNA COVID-19 vaccine dose in the 28 days prior to the spontaneous abortion. Secondary objectives were to evaluate the odds ratios for receiving a third messenger RNA vaccine dose in a 42-day window and the odds of receiving any COVID-19 vaccine booster in a 28-day or 42-day window. Next slide. Booster doses were defined as COVID-19 vaccine doses administered at least 28 days after completion of the primary series. Primary analyses focused on a third messenger RNA COVID-19 vaccine dose after 2 prior messenger RNA COVID-19 vaccine doses, as this was the most common booster type in our population. Secondary analyses evaluated any booster type, with examples shown on the slide. These analyses preceded availability of the bivalent vaccine. Next slide. This figure shows our approach for the primary analyses. Using a validated algorithm, we identified spontaneous abortion 6 to 19 weeks gestation and assigned these cases to a 28-day surveillance period based on the pregnancy outcome date. We then looked for exposure to a third messenger RNA COVID-19 vaccine dose in a 28-day window prior to the spontaneous abortion. Next slide. Now we have added to the figure the ongoing pregnancy period controls. Ongoing pregnancies 6 to 19 weeks gestation identified using the same validated algorithm were assigned to 1 or more 28-day surveillance periods. Within a single 28-day surveillance period, we then assigned the midpoint as the index date and looked for vaccine exposures in a 28-day window prior to the index date. Next slide. For the primary analyses using generalized estimating equations, we then calculated the odds of exposure to a third messenger RNA COVID-19 vaccine dose in 28 days prior to spontaneous abortion compared to the odds of exposure to a third messenger RNA COVID-19 vaccine dose among ongoing pregnancies in the 28 days prior to an index date. This slide also adds secondary analyses applying a 42-day exposure window and changing the exposure to any COVID-19 vaccine booster. Next slide. In primary analyses, our population included 112,718 unique pregnancies from November 1st, 2021 through June 12th, 2022. Of these, 14,226 ended in a spontaneous abortion. Among ongoing pregnancies, 10.6% received a third messenger RNA COVID-19 vaccine dose before 20 weeks gestation, while 6% of pregnancies ending in a spontaneous abortion received a third messenger RNA COVID-19 vaccine dose while pregnant. Counts and breakdown by vaccine type are shown on this slide. Next slide. For our primary analyses, receiving a third messenger RNA vaccine dose in a 28-day window was not associated with spontaneous abortion. Adjusted odds ratios was 0.94 and 95% confidence interval was 0.86 to 1.03. Results were similar when stratified by vaccine type. Next slide. This slide now shows the adjusted odds ratios and 95% confidence intervals for our primary and secondary analyses. Adjusting the exposure window from 28 to 42 days or expanding the booster definition from a third messenger RNA vaccine dose to any COVID-19 vaccine booster dose did not substantially change our findings. Next slide. The analyses presented on spontaneous abortion and COVID-19 booster vaccines are part of a large portfolio of VSD work monitoring COVID-19 vaccine safety and pregnancy. The table on this slide offers an overview of the many ongoing VSD studies in this area and the status of this work. Some of these studies have been previously disseminated through presentation or publication. For others, the analyses are ongoing or we are waiting for infants to reach a critical age. We are currently evaluating safety of the primary vaccine series and the monovalent boosters. Along with spontaneous abortion, additional outcomes include stillbirth, fever and other local and systemic reactions, small for gestational age and preterm birth, pregnancy complications, major structural birth defects, and growth and developmental outcomes. Next slide. In summary, COVID-19 booster vaccination in early pregnancy was not associated with increased risk for spontaneous abortion. The Vaccine Safety Data Link is continuing comprehensive surveillance of COVID-19 vaccine safety and pregnancy. To date, no safety signals have been identified. Future studies will evaluate long-term outcomes and possibly the new bivalent vaccine. And next slide. I'd like to thank our large team who made this work possible, and I'll pass the baton to Dr. Olson.
Thank you. Next slide, please. Okay, thanks. So we'll now transition to discussing information from CDC's vSafe COVID-19 Vaccine Pregnancy Registry, which we last discussed during a previous ACIP meeting in fall of 2021. Let me start by briefly reviewing the enrollment and data collection process for the registry. Starting with the rectangular box on the left, people who voluntarily enrolled in CDC's vSafe after vaccination health checker indicated they were pregnant at the time they received a vaccine, or if they became pregnant after vaccination at later check-in points. Individuals reporting a pregnancy were then called and screened for eligibility for the pregnancy registry. As shown in the middle box, eligibility was based on when they reported the pregnancy into vSafe, meeting the age criteria of being 18 years or older, whether they were an English or Spanish speaker, and whether they were either pregnant at the time of vaccination or were vaccinated in the periconceptional period, defined as the 30 days before the first day of the last menstrual period before the pregnancy. Eligible individuals were then consented for pregnancy registry enrollment and interviewed by phone at designated time periods over the course of their pregnancies, postpartum, and after the infant would have reached 3 months of age. Note that not all participants were interviewed during all trimesters of pregnancy, as they may have entered the registry at any point in this continuum, and some initial interviews were conducted after delivery had occurred. Participants were also asked if they would consent to obtain medical records for the pregnancy and infant up through 3 months of age. Pregnancy registry interviews began in January 2021 and were completed in August 2022. Medical record requests and reviews for select outcomes and conditions are still ongoing. Next slide, please. There were over 65,000 potential participants who reported a pregnancy into the vSafe after vaccination health checker during the eligibility period. Attempts were made to reach all potential participants, with about 60% unreachable. Overall, 36% of potential participants were contacted and determined to be eligible for enrollment. Of these, 98% enrolled. In total, there are 22,953 participants enrolled. 15 participants contributed more than one eligible pregnancy. The distribution of vaccine type received is shown here and demonstrates that the majority of participants received one of the mRNA vaccines. This was due to the timing of the rollout of the vaccines and the lower uptake of Johnson & Johnson. The mean age of participants is 33.9 years. 45% reported they worked in healthcare, and 79% described themselves as non-Hispanic white. Next slide, please. Among registry participants, the timing of the COVID vaccine, which made the participant eligible for the registry, is reasonably distributed across all pregnancy time periods, shown here. About 10% of participants were vaccinated in the periconceptional period, about 28% were vaccinated in the first trimester, and about 2/3 of participants were vaccinated in the second or third trimesters. Next slide. These next two slides give an overview of outcomes for the completed registry cohort. Pregnancy outcomes are self-reported by registry participants, with the exception of stillbirths. Self-reported stillbirths have been adjudicated and reclassified if needed, based on medical records when these have been available. Overall, in this table, if you look across the rows at the bolded numbers, you can see that the proportions of live births and fetal losses were similar by vaccine type. At the bottom, the proportion of registry participants reporting stillbirth was 2.45 per 1,000 live and stillbirths, which is lower than the background rate from the U.S. National Vital Statistics System, where the stillbirth rate is 5.89 overall and 4.89 among the non-Hispanic white population, which again is most similar to our cohort. Next slide. Here we summarize the incidence of self-reported medical conditions, pregnancy complications, and infant outcomes by vaccine type. The column on the far right lists published incidence rates for comparison. Again, scanning across all outcomes and vaccine types, the incidence observed in the pregnancy registry was similar to or below available background rates. Next slide. For the sake of time, I'm going to skip the details on this slide, as this analysis was presented at a previous ACIP meeting, where we reported no increased risk of spontaneous abortion or miscarriage before 20 weeks of gestation among the registry participants. Next slide. In an analysis of the first half of the registry cohort, Major birth defects were reported for 429, or 3.5% of fetuses or infants. The purple bar is the overall prevalence of birth defects among all vaccine types received at any time during pregnancy. The red bar represents the prevalence of birth defects among those who received an mRNA vaccine during the first trimester. The blue is the prevalence among those who received an mRNA vaccine after 20 weeks gestation. There was no statistical difference between those vaccinated in the first trimester and those vaccinated later in pregnancy after 20 weeks. All of these prevalence estimates fall within the 3 to 5% expected prevalence for major birth defects, as is reported in the literature. Next slide, please. Finally, in an analysis of over 20,000 registry participants with pregnancies ending after 20 weeks of gestation, we compare the prevalence of multiple outcomes of interest, including stillbirth, preterm birth, gestational hypertension, NICU admission, and maternal ICU admission in the registry participants who reported no SARS-CoV-2 infection during pregnancy with those participants who reported SARS-CoV-2 infection after being fully vaccinated. Other studies have reported an increased risk of poor pregnancy outcomes among unvaccinated pregnant people infected with SARS-CoV-2. Although the pregnancy registry does not include an unvaccinated control group, as you can see from the prevalence ratios presented in bold on the right, infection after full vaccination was not associated with an increased risk of those outcomes compared to those who were vaccinated and had no reported SARS-CoV-2 infection. Next slide, please. In conclusion, the VSafe COVID-19 Vaccine Pregnancy Registry adds to the accumulating evidence on the safety of COVID-19 vaccination during pregnancy. To date, the pregnancy registry has not identified any concerning safety signals, including any increased risks of adverse pregnancy-related outcomes for either the registry participant or the infant, or any disproportionate outcomes by vaccine type or timing. Several findings reported today are from early analyses while data collection was ongoing. While all early analyses will be replicated with the final full cohort of registry participants, there's no reason to expect that associations would change over time. For select outcomes and conditions, the acquisition and abstraction of medical records is still in progress. This effort, which takes additional time and care, will aid in confirming and/or identifying conditions such as birth defects, where participant-reported information may have been insufficient in detail to make an accurate determination. Finally, CDC will continue to monitor the safety of COVID-19 vaccination during pregnancy with an extended follow-up through 15 months post-delivery or end of pregnancy. Follow-up calls are scheduled to begin in November. Next slide. I'd like to end by thanking the registry's participants for generously sharing their time and information with us, and the many people who support the registry, particularly our data team led by Dr. Andrea Sharma for their assistance in preparing this presentation. Next slide. Thank you.
Thank you very much, Drs. Ellington, Carbonda, and Olson.
Oh, sorry, there's one more presentation.
Oh, there's one more.
Yes.
Okay, let's keep going.
Sorry, next slide. Great, so now we'll transition to talking about effectiveness of maternal COVID-19 vaccination among pregnant people and infants. And as a reminder, CDC recommends that everyone stay up to date with COVID-19 vaccination, including all primary series doses and the most recent booster dose recommended for them by CDC. And specifically, people ages 5 years and older are recommended to receive one updated bivalent mRNA booster dose. And staying up to date with COVID-19 vaccinations is recommended for everyone, including people who are pregnant, trying to get pregnant now, who might become pregnant in the future, and people who are breastfeeding. Next slide. This slide has been shown at ACIP previously and shows the difference in the composition of monovalent and bivalent mRNA vaccines using the 30 and 50 microgram doses as examples. Monovalent mRNA vaccines contain mRNA encoding the spike protein from the ancestral or original SARS-CoV-2 virus, whereas bivalent vaccines containing mRNA encoding the spike protein for both the ancestral strain and the Omicron BA.4/5 variants. Because bivalent vaccines were first recommended on September 1st of this year, there has not yet been time to assess effectiveness of bivalent boosters among pregnant people and infants, so the data I will show reflects monovalent vaccines. Next slide. We'll start with discussing monovalent mRNA vaccine effectiveness among pregnant people. Next. I believe you're all familiar with the VISION network, and the analysis I'm presenting today used a test-negative design to assess monovalent mRNA vaccine effectiveness against COVID-19 associated emergency department and urgent care visits and hospitalizations. Next slide. This graph shows monovalent vaccine effectiveness for emergency department and urgent care visits occurring among pregnant people and non-pregnant women. Let me orient you to this forest plot, which shows vaccine effectiveness among pregnant people in the top half, including those vaccinated either before or during pregnancy, and vaccine effectiveness among non-pregnant women ages 18 to 45 years in the bottom half. Delta vaccine effectiveness estimates are in the middle columns, and Omicron is on the right. All vaccine effectiveness estimates are then stratified by number of doses, with 2-dose estimates shown in green and 3-dose estimates in blue, and by days since last dose, shown in the parentheses after the number of doses at the beginning of each row. So looking at the Delta estimates, again in the middle, among pregnant people, vaccine effectiveness for emergency department and urgent care visits occurring during pregnancy was high at 78% or above for both 2 and 3 doses. Among non-pregnant women, we can see that the power is higher, as evidenced by narrower confidence intervals, but the vaccine effectiveness estimates and patterns are the same. Effectiveness was high, waned a little after 150 days after dose 2, and was restored by a 3rd dose. Now let's focus on Omicron, shown on the right side of the graph. And as we all know, the Omicron variant can evade monovalent vaccine-induced immunity more than prior variants did. And these estimates reflect mismatch between the monovalent vaccine and the Omicron variant. As expected, vaccine effectiveness for emergency department and urgent care visits is lower during Omicron predominance than it was during Delta. And among pregnant people, effectiveness waned to non-significant or not different than 0 by 150 days after dose 2, but was restored by a 3rd dose. We see similar patterns among non-pregnant women, with waning over time after dose 2, restoration of effectiveness after a 3rd dose, but then waning again over time after dose 3. Next slide. This graph, which is set up the same way, now shows vaccine effectiveness against hospitalization. During Delta, again in the middle, vaccine effectiveness was very high, 98 to 99% among pregnant people, and 90% and above among non-pregnant women. During Omicron predominance, shown on the right, the study had more limited power due to lower numbers of hospitalizations. Among pregnant people, vaccine effectiveness at 7 to 119 days after dose 3 was 94%. Among non-pregnant people, vaccine effectiveness was 50 to 73%. Next slide. These data indicate that vaccine effectiveness of monovalent mRNA vaccines for COVID-19 associated emergency department and urgent care visits and hospitalizations is similar among pregnant people and non-pregnant women. I did not show these data, but in the published paper, vaccine effectiveness was also similar when stratified by doses given during pregnancy to that of doses given before or during pregnancy. Thus, time since last dose likely affects vaccine effectiveness for these outcomes more than whether vaccine doses were given before or during pregnancy. And vaccine effectiveness is lower during Omicron predominance compared to Delta in both pregnant and non-pregnant people. And this is likely due to a combination of factors, including mismatch between monovalent vaccine and the variant. Next slide. Now we'll transition to talking about effectiveness of maternal vaccination among infants. Next slide. These data come from the Overcoming COVID-19 platform, which assessed vaccine effectiveness of maternal monovalent mRNA primary series given during pregnancy and prevention of hospitalization for COVID-19 in infants ages 0 through 5 months. Vaccine effectiveness estimates are stratified by variant time period, with Delta in the top half and estimates shown in purple, and Omicron in the bottom half with estimates in black. And estimates are stratified by timing of the second vaccine dose, at any time during pregnancy, during the first 20 weeks, or after 20 weeks. Next. What we can see here is that most importantly, maternal COVID-19 primary series vaccination protected infants ages 0 through 5 months from hospitalization for COVID-19, and overall protection was lower during Omicron predominance than during Delta. When vaccine effectiveness was stratified by timing of vaccination, during Delta, effectiveness estimates for hospitalizations were not significantly different. However, during Omicron predominance, vaccine given in the first 20 weeks did not show effectiveness in infants, whereas it did give protection if given after 20 weeks. Next slide. So in summary, COVID-19 can cause severe disease in pregnant people and infants. COVID-19 vaccination of pregnant people is safe for pregnant people and infants. Maternal monovalent mRNA COVID-19 vaccination protects pregnant people and infants ages 0 through 5 months from COVID-19, including from severe disease and hospitalization. And monovalent vaccine effectiveness was lower during Omicron predominance when there was mismatch between the vaccine and the predominant circulating variant. Thus, bivalent vaccines have the potential to improve protection against circulating new Omicron variants. And this is why CDC recommends that everyone, including people who are pregnant, trying to become pregnant, may become pregnant, who are breastfeeding, should stay up to date with COVID-19 vaccines and get the recommended updated bivalent booster when eligible. Next slide. And lastly, as a reminder, CDC's guidance on staying up to date with COVID-19 vaccines and co-administrations of vaccines applies to everyone, including pregnant people. COVID-19 vaccines may be administered without regard to timing of other vaccines, and this includes simultaneous administration of COVID-19 vaccine and other vaccines, such as influenza vaccine and Tdap or pertussis vaccine on the same day. There are additional considerations if administering an orthopox virus vaccine, and these can be found on CDC's website. Next. This presentation reflects the work of many people whom I would like to thank. And next. And now we're ready for questions.
All right, thank you. So I'm going to thank now doctors. Let's see if we can go back. Doctors Ellington, Olson, Carbonda, and Fleming-Dutra for that series of presentations. And these presentations are now open for questions. Dr. Sanchez.
Thank you. Now, it's great data showing the safety of these vaccines. My question is, do we have any data on the monoclonal use during pregnancy? Were these women, the pregnant women, did they, in addition, have monoclonals, or do you capture them?
And thank you, Dr. Sanchez, for that question. In clarification, is that in regards to the vaccine effectiveness data or the safety data? I'll answer from the vaccine effectiveness. I do not believe that that was part of the analysis that was included from the VISION analysis among pregnant people or overcoming COVID, so we don't know that answer. And I'll defer to Drs. Olson and Carbonda regarding the safety data. Dr. Olson, do you want to start? Okay, go ahead.
This is Dr. Elise. We don't have that data on VSD for our vaccine safety evaluations.
Will that be captured in the interviews with the Be Safe? They're doing the 15 months.
Sorry, Dr. Sanchez, I can't hear you.
I was just wondering if that data could be captured in the Be Safe follow-up study that they'll be doing.
Dr. Olson?
Hi, this is Christine Olson. That is not information that we're collecting. We're focused on the vaccine, and so we have not been collecting information on the use of other therapies.
Thank you. We'll move on to Dr. Sineas.
Thank you. I have a question about the VSafe data. 45% of participants were healthcare workers. Do we have any subgroup analysis of outcomes in the participants that were non-healthcare workers?
We haven't looked at that yet. We are still working on the further data evaluation of what we're calling phase 1 of the registry. So the interviews that were conducted during pregnancy and in the 3 to 4 months following pregnancy. And that we have not done subgroup analyses at this time. I'm not sure that we'll have adequate numbers to be able to report out in a manner that'll be helpful, but we are aware and have always been aware that there's a relatively large proportion of our participants that came from the healthcare field just because of their early access to the vaccines based on the staged rollout. Over time, that has steadily declined, and the cohort that we have has become more diverse, but they still are overrepresented within the cohort. Thank you.
Thank you. Dr. Paling?
I want to say thank you very much for the tremendous amount of information that you've shared. And I want to make sure that I've understood it correctly, and I'm trying to combine a whole bunch of different presentations. So, I'm sorry. I can talk into the microphone. What I'm understanding is that under the Omicron epidemic, the rates of COVID-19 in children 0 to 5 months of age is getting close to the 65 years and older, and 3/4 of them are healthy. and that moms that get COVID during pregnancy have an increased risk of being admitted to the ICU themselves. There's an increased risk of stillbirth, there's an increased risk of preterm delivery, and there's an increased risk of neonatal death. And that if moms get the vaccine during pregnancy, it's safe, and there is much better outcomes, and there's protection not only for the mom, but there's also protection for that child. Is that correct? Thank you.
Yes, thank you for that excellent summary.
Yes, thank you. And you missed all of the heads nodding behind you, Dr. Peeling. All right, next we'll move on to Dr. Brooks.
Yeah, excuse me, excellent presentation. It's the type of thing we need when we make recommendations to pregnant people. In the first presentation, the overall rate of stillborn was 2.45 for those that were vaccinated. And that slide had a 5.89 on it, said overall. Was that the background rate? I just want to understand what the background rate is for stillborn. Was it 3 to 5%? I just get clarification on that.
What you said initially, the 5.89 is the background rate from the National Vital Statistics data.
Okay.
And the 3 to 5% was for birth defects.
So
Background rate.
So it's not showing that the vaccine is actually protective against these things. That's what I'm trying to get to. Is the rate lower among vaccinated in terms of stillborn and birth defect?
I will chime in. There is at least one systematic review and meta-analysis that has been done by Prasad et al. That does show a protective effect among those vaccinated against stillbirth, likely mediated through the prevention of COVID-19 illness. So because there is such a strong effect of illness on stillbirth, of infection on stillbirth, getting vaccinated does protect against that. And so there is some data to show that.
All right, and so that wasn't explicitly stated, so that's actually kind of interesting.
Agree.
Thank you, Dr. Daly.
Yeah, thanks so much. Could you pull up the slide in Dr. Carbonda's presentation? I think it was slide 26, which was a summary of the VSD safety in pregnancy studies. Yeah, that's great. So, Dr. Carbonda, this isn't a specific question for you. It's sort of a backdrop for a point that I want to make. So it would be hard to summarize any better what Dr. Paling just said. That's the most beautiful summary that I've heard. But I think the point that I want to make is that, I think for pregnant women, these are complicated decisions, and they have a lot of things they're considering. One is their risk. Another is their individual risk, but often they're thinking risk to the pregnancy, and then how's their baby going to do? And I think in the context of that, at least what I have heard in talking to women is that they're most concerned about safety. They want to know, is it safe? And they're very risk averse. And so I think, and when these vaccines were first authorized, there was an acknowledgement, we have less data about safety, and that was an explicit acknowledgement. But I think we're in a really different place 2.5 years into the pandemic, and I think that to be able to articulate what's on the slide here and say, the safety is being exhaustively studied and very reassuring, I would hope would provide reassurance and then increase vaccination rates. And so I guess my ultimate question is, I find this data very compelling, and I can't summarize it better than Dr. Paling, but how do we communicate this as broadly as possible so that we can increase coverage? Over.
Thank you, Dr. Daly. Dr. Long, do you have a way to frame that for us?
No, I wouldn't ever even try. But what I was thinking about is that we have very limited therapeutics for 0 to 5-month-olds who have coronavirus infection. And so I would think that these data are very hopeful in us promoting this is the best way to protect your baby from death from coronavirus. And that's really impressive, and I hadn't seen this before, so it's startled me and is very hopeful. Do we know, Dr. Ellington, of the 0 to 5-month-olds with hospitalization, ICU, and death, what percentage of their mothers were vaccinated? The data that you showed us, I think it was your slide 13, well, I don't remember what it was.
Hi, Dr. Long. I can answer that question for you. In this particular data, we do not know the percent that were vaccinated in the COVID-net surveillance.
I didn't hear that. I'm sorry, my hearing problem. What percent of those babies who were hospitalized, mothers, were vaccinated?
We don't have those
don't
data in
know.
the COVID-net
Okay, thank you.
surveillance platform.
Thank you.
Dr. Sanchez?
So, no, and I agree. I think that there's still a lot to be done with only 48% of women having received the primary series. But my question is about the granularity of the infant deaths, and are we capturing any on the multi-system inflammatory conditions in neonates? Is that, I know that might be a separate area, but I do think that needs to be included in terms of the pregnancy and neonatal outcomes. And as an aside, I'm also not surprised about the increase during the Omicron era, because we've seen also higher transmission to normal newborns during the months, during the summer when Omicron was circulating. And our transmission previously had been only from mother to normal newborn, or to in the first few days, had been only like 1%. It went up to like 5 or 6%, and in these babies.
Thank you.
So I'll try to answer for that. Regarding the multi-system inflammatory syndrome in children, the death counts are from the National Vital Statistics system. So if COVID-19 was listed as potentially a cause of death on the death certificate, then that's what's captured in those death counts. CDC separately conducts surveillance for multi-system inflammatory syndrome, and I apologize, our MISC experts were unable to join today for Q&A, but we can follow up with numbers specific to that group. MISC can occur in this age group, but I don't have the numbers at my fingertips.
Thank you. Dr. Long?
Mine was the same question, really asking whether on slide 13, you're using the words "had COVID-19 symptoms" specifically to mean COVID lower respiratory tract-like symptoms, which I think of as COVID, which is adult disease, compared with children who may have at this age sepsis, fever, hypothermia, apnea, or multi-system inflammatory syndrome. I've never seen that in this age group. So do you know, are you using the word specifically, or are you just saying symptomatic with coronavirus infection?
So there's a number of COVID-19 symptoms that are captured in that particular group of COVID-19 symptoms. Dr. Hamid, who did the analysis, is standing behind us, but I also want to refer to Dr. Chris Taylor, who I believe is on the line from COVID-19. He may be able to answer more specifically regarding what's included. It's a very long list of symptoms. Dr. Taylor?
Yes, thank you. Actually, I would refer to Dr. Hamid if she does have that list of symptoms. As you had mentioned, it is relatively long. I know that we do capture symptoms that are specific to infants, including things like cyanosis, but I don't know if Dr. Hamid might have that extensive list handy.
Yes, so it's a very long list of symptoms. They're non-specific symptoms. I don't have the list right in front of me, but as has been pointed out, it is very broad.
That would, if it's not in publications, it would be really great to include, because we do see a broader range of symptoms in infants. And also wanted to recognize what Dr. Sanchez said about some people are calling it MIS in the neonate versus MISC, but it is also a severe consequence of COVID and something that we hadn't seen earlier when we didn't have so many babies infected. So I do see one additional, sorry, Dr. Daly, and then we'll go to Ms. Hayes right after that.
So what I'm trying to do is connect what we know about vaccine efficacy of vaccinating the mom for protection of a 0 to 5 month old, and then this slide, which says 265 deaths with 0.5% of all deaths in this age group. And I don't want to go too far beyond what the data will say, but to me, this seems like it's vaccine preventable death, or at least high potential for these neonatal deaths to be vaccine preventable. Again, I don't want to go too far beyond what the studies show, but if we're preventing disease in infants and infants are dying from COVID, it seems that that's a reasonable interpretation of the data that we see to date.
Thank you. I'm going to go to Ms. Hayes, and then we'll go to, do you want to respond, Dr. Long? Okay, quick response.
Yep. So I agree. So there are several things that have changed. One is we have more data on the safety in pregnancy, and we have more data on the risk in pregnancy for the mother. And the Omicron part is brand new. This is brand new information about vaccine preventable deaths. I think we could use those words. So it seems like it's new energy with new data that ought to inform pregnant women that you can see. Previously, without much data about safety, you might say, I'll take my chances, I'll wear my mask. But now with Omicron really being transmitted in all kinds of ways, easier, we don't understand, these are vaccine preventable deaths of infants.
Thank you. We'll go to Ms. Hayes.
Yes, Carol Hayes with the American College of Nurse Midwives. I have a comment and a question. My comment is that I think anytime you're talking about adverse pregnancy outcomes, it's really important that you have the background rate on almost every slide just to keep the data relevant. And I think that Dr. Brooks's question about is this vaccine actually protective against stillbirth and other outcomes, adverse outcomes? I mean, I thought that was a great question. So my question is for Dr. Ellington on slide 9. And I have some questions about that survey. So my experience is that 77% of women are not vaccinated. Pregnant people are not vaccinated. And so I'm curious how this survey was done, how it was sent out, who it was sent to.
So this is the survey data. So the two data sources were provided to sort of corroborate the two rates. And so the first the first data source is the National Immunization Survey adult module. And within that, they have questions, and it stratifies by whether the woman is pregnant, recently pregnant, trying to become pregnant, or not in those categories. And so I would refer to the citation there for the exact methods on how the National Immunization Survey is implemented, but it is a survey implemented among the adult population and then weighted to be nationally representative. And I will point out, like, well, you haven't asked about the second one, but we provide the second data source as well, which is through electronic health systems. And so these are two different ways to get at what we think the current, overall estimated coverage of vaccination and pregnancy is. And as you can see, while they are not the same, they are similar in terms of their estimates. And so certainly there are things that affect these estimates. With the first data source, response rate is going to affect that. And so those who were unvaccinated may be less likely to respond to surveys. And so there can be some bias in that estimate. But I think the second data source supports that overall receipt of the primary series among pregnant people is quite high. And this is not necessarily that they received the vaccination during pregnancy. Overwhelmingly, these people were all vaccinated before they became pregnant. And then the additional data point is among those who received the primary series, among how many were vaccinated. And then I would also, refer you to the insert there that shows when you multiply the 72% by the 60%, you get 43%. And so that's really how many pregnant people that we estimate are currently either unvaccinated or undervaccinated, which is, more than half of the pregnant people. So there certainly are, limitations to both data sources and their representativeness and, what the response rate might be for the survey. But I don't know if there's anybody else who would like to provide more details on the methods for the National
I would also just be really
data.
curious what the percent of public insurance and private insurance is in this population, because in my experience, I've worked largely with women on Medicaid, pregnant people on Medicaid, and they are highly unvaccinated.
Right.
So,
I believe
I find this data to be a little sketchy.
Yeah, there are several publications with these data, and I believe those publications do provide the breakdown of the insurance coverage for those participants. So we could provide that. You want to go ahead?
Thank you.
And Carol, this is Dana Meany-Delman. Good to hear your voice. We have been trending this over time, and we did see during the Delta period, and especially when CDC released the HAN and ACOG and SMFM and CDC promoted vaccines in the very targeted way during the Delta period, that we did see an increase during that period of time. So I do think it's trended in the right direction, but in general, maternal immunization, we still have a ways to go to promote all vaccines during pregnancy that we know are safe. So I agree with you that inherently we still have a lot of work to do in the space of acceptance of maternal vaccination. And I think Matt Daly's point was well taken, vaccine preventable deaths among kids, but also vaccine preventable deaths among women. We know in August of 2021, we saw a large number of pregnant people in the ICU, and many of them died. So we do have, vaccine preventable deaths for the moms, for sure. We have good data to suggest that. So now we have the added benefit, but we still very much as a practicing OBGYN have an uphill battle. And you're right, Carol, it is very hard still to promote acceptance in this population. And hopefully this will help us galvanize more support for that.
And just to add one additional thing too, is that we do see significant differences when we look at various factors, including the insurance coverage, but also by race and ethnicity. And so both these data sources do provide have estimates where you can look at what those estimates are by different race and ethnicity groups, and there are significant disparities there.
Thank you, Dana. Good to hear your voice.
I see one more hand raised in the Zoom meeting. So Dr. Young.
Yes, I wondered if you stratified the infant outcome data for whether they were breastfed or not, and if you did you see a difference?
So this is Dr. Fleming-Dutra. I'll speak to the vaccine effectiveness study in overcoming COVID. Unfortunately, information on breastfeeding for the infants was highly missing in that particular study, and so they weren't able to control for it. So we don't know that regarding the overcoming COVID-19 vaccine effectiveness study. And I'm not sure if it's available. It is not available, it appears, Dr. Hamid is saying, in the COVID-net surveillance data either.
I would suggest that we include it asking the question, because it may make a difference in your infant outcome.
I'll just add from the VSD, we do have one study that will include breastfeeding information, the study following up infant infections following maternal vaccination. So VSD is headed in that direction for vaccine safety work.
Wonderful, thank you.
Thank you. I'm going to call on Dr. Romero.
So Dr. Meany-Delman stole my thunder, but I think it's very important for CDC and I'm glad that this data was presented. It's very important for CDC and put a priority that pregnant women receive their immunizations and boosters. As you have seen, there is data to show that it is safe, effective, and protective for the mother and the infant itself. So again, these data reinforce this. And hopefully people will listen more to the need to get this done. I can tell you that as a Secretary of Health, I heard of cases in my state of women that wound up in the emergency room, that wound up on a ventilator for long periods of time, and some died. And so it is a terrible thing. We can prevent that. So again, safety of the vaccine and efficacy is well shown.
Thank you, Dr. Romero. I see Ms. McNally has raised her hand, and then I have two more hands here.
Thank you, Dr. Lee. Just to follow up on Dr. Romero's point there, for the benefit of the public, can someone please identify the best time frame to get vaccinated during pregnancy? Thank you.
So this is Dr. Fleming-Dutra. So I think the important part is that pregnant people, as well as everyone, should stay up to date with COVID-19 vaccinations, and then the best time to get vaccinated with your bivalent booster is when you're eligible. As we can see from the data that, the vaccine effectiveness during Omicron was lower than it was with previous variants, and this probably likely has a lot to do with mismatch of the monovalent vaccine for the circulating variant. So everyone should get vaccinated and stay up to date when they're eligible.
And I think we need to remember this is Dr. Mini-Dillman. We need a healthy mother to have a healthy baby.
Thank you. Dr. Long.
Just a clarifying question, Dr. Fleming-Dutra. On your slide 49, where you show us the protective effect on the first 5 months of life, are these women who were immunized during pregnancy? I suspect they were, rather than having a history of vaccination.
Yes, Dr. Long, that is correct. So these were pregnant people. These mothers were immunized during pregnancy, and you can see that where the rows are, we have the vaccine effectiveness estimate stratified by timing of the second dose during pregnancy. So that first row under each variant period is any time during pregnancy, second dose in the first 20 weeks of gestation, and then second dose is after 20 weeks of gestation.
So that'll raise the question for the work group to think about, since we don't think that this vaccine protection is long-lived in the population, we've had lots of boosters, will there need to be consideration of boosting during pregnancy or attempting to get to that 6 month or whatever you determine it is, so you can continue to provide the mother protection and the infant's protection?
Yeah, Dr. Long, this is Dr. Oliver. I think continuing to assess both the safety and effectiveness data, both in pregnancy and then in infants, is a top priority of the work group. And so we wanted to get these data out, have everybody aware, because I fully agree that knowing there's vaccine preventable disease in pregnant people and in infants right now. So we need to do what we can with the vaccines and the authorizations we have right now. But yes, we also have a long list of things that we like to talk about for ways that we can kind of optimize the vaccine recommendations in the future, and this is absolutely one of the things that's on the list. Thanks.
Thank you. Dr. Eckert?
Hi, thank you so much for this presentation, for taking the time to really look at this data and present it in this large public forum. I just want to go on the record on behalf of the American College of Obstetrics and Gynecology and just say that we are continuing to work and will work even harder to get this out to all of our providers, that only half of pregnant individuals are vaccinated, and the benefit both to the mom and the baby. And so many of us have cared for these women in the intensive care units and had to make the hard choices of delivery early, et cetera. And so I just want to reaffirm the importance of this data and thank you for showing the spotlight on it.
Thank you. I'm just going to say one more thing, just to reiterate. I think with full confidence, I feel as a provider, I can strongly recommend this vaccine to my patients, to my pregnant patients who are about to have children. So I hope this gives that sense of the amount of confidence we've seen, because this is actually very strong data. We'll go on to Dr. Sarah Oliver next for the next section of the COVID-19 session.
Great, thanks so much, and good afternoon. Next slide. So we've previously presented details of the COVID-19 pandemic in children, and then we obviously just heard about the COVID pandemic among infants less than 6 months of age. This slide shows the updated hospitalization rates for pediatric age groups that are vaccine eligible. And you can see that since this past winter's peak Omicron surge and really throughout 22, the 6 months through 4-year age group has had the highest hospitalization rates, again, among the pediatric age groups who are vaccine eligible. Next slide. This slide provides an overall timeline of recommendations for pediatric COVID-19 vaccines and how the vaccine policy has evolved over time. The top row shows the recommendations for the primary series, both expanding the ages down to the 6-month population we saw this summer and broadening to include both mRNA and protein subunit vaccines. Then the bottom row is for booster doses, again, both expanding by vaccines and ages to include the recent bivalent vaccine authorizations. Next slide. Then at previous ACIP meetings, we've discussed booster recommendations for children and adolescents 5 years of age and over for the monovalent Pfizer boosters. For adolescents, the booster recommendations came during the peak of the winter Omicron surge and was informed by safety data from Israel, waning antibody titers and vaccine effectiveness after a primary series in the setting of Omicron, and building on data from the booster recommendations in adults. For children ages 5 through 11 years, recommendations were based both on a clinical trial for booster doses in this age group, as well as the post-authorization safety data from primary series. The booster doses in children ages 5 through 11 achieved antibody levels higher than what was seen after the primary series. The reactogenicity after a booster dose was similar to what was seen after a primary series, and the rates of myocarditis after a primary series in children 5 through 11 were considerably lower than rates seen in adolescents. Next slide. Then for the monovalent Moderna COVID-19 vaccines, the booster dose was studied in around 2,600 children and adolescents, with the specific doses and ages listed here. There was one SAE in a child aged 5 through 11 that was unrelated to the vaccine, and no SAEs in adolescents were in the trial. Reactogenicity symptoms were again similar to what was seen for booster doses in other age groups, and antibody levels after the booster dose were 4 to 5 times higher than what was seen after the primary series. So it was based on these data that FDA authorized and CDC recommended Moderna boosters for children 6 through 17 years of age. Next slide. Then, as we heard and discussed at the September 1st ACIP meeting, data were reviewed to inform the bivalent mRNA COVID-19 vaccines for all individuals ages 5 and over who were previously recommended to receive a monovalent booster dose. This included post-authorization VE and safety data from over 600 million mRNA vaccine doses that were administered, clinical data from the bivalent COVID-19 vaccines in over 1,700 people, including antibody studies and antigenic cartography data and modeling data. Next slide. Then ACIP has discussed myocarditis in COVID-19 vaccines numerous times. The risk of myocarditis and pericarditis has been identified after mRNA COVID-19 vaccines. The risk is rare and is primarily observed in adolescent and young adult males within the first week after receiving the second dose of a primary series or the booster dose of the mRNA COVID-19 vaccine. We also know from data previously presented to ACIP that most individuals with myocarditis have fully recovered at follow-up. And the risk of adverse cardiac events were 1.8 to 5.6 times higher after SARS-CoV-2 infections than after the mRNA COVID-19 vaccine among males 12 to 17 years of age. We do also know that an interval of 8 weeks between the vaccine doses may further lower the myocarditis risk. Next slide. Understanding the balance of benefits and risks to inform vaccine policy is critical. It's important to make sure that vaccine policy decisions always take the entirety of the data into account, including the benefits of the vaccine and the risk that the infection poses as well. ACIP has reviewed the balance of benefits and risks regularly. This slide shows the variety of times that ACIP has discussed this for a range of ages and policy questions. And each time, ACIP has evaluated the benefits and risks of these mRNA COVID-19 vaccines. ACIP has determined that the benefits outweigh the risks. Next slide. Then CDC and FDA have conducted rigorous post-authorization monitoring for COVID-19 vaccines. Since authorization, so this is starting in January of 2021, there have been 22 ACIP meetings focused on COVID vaccines. We've had vaccine effectiveness data presented at 11 of those meetings, and safety data has been presented at 20 of the 21 ACIP meetings. CDC evaluates VE through multiple observational studies, employing various methods, and using information collected through different surveillance platforms, electronic health records, or prospective studies. And we know that COVID vaccines continue to undergo the most comprehensive and intense safety monitoring in US history. Then these data are routinely presented to ACIP, currently averaging at least one ACIP meeting a month, where both safety and effectiveness data are presented and discussed. Next slide. For example, this slide was shown back in September for the VE data for emergency department visits in pediatric age groups. The data for these are for the monovalent COVID vaccines, and we eagerly await post-authorization VE data for the bivalent vaccines at upcoming ACIP meetings. Next slide. Then again, as a reminder, this slide was shown at the September 1st ACIP meeting, where we had safety data from the primary series in young children presented, both highlighting no increased risk of myocarditis in this age group and overall the reassuring safety profile. Next slide. Then the next two slides are the myocarditis data from the COVID-19 safety surveillance that was again shown at the September ACIP meeting in those ages 5 and over. These are the VAERS data. Next slide. And then these were the VSD data that were shown in September. Next slide. So now we'll walk through COVID-19 vaccine uptake among children and adolescents. For children 6 months through 4 years of age, 1.4 million children have had at least one COVID vaccine, which is just under 7% of children in this age group. Then among children 5 through 11 years, 11 million first doses, or 38% of children, and 1.4 million booster doses have been given, or 15% of children in this age group who've completed a primary series. Then for adolescents, 18 million have received a first dose, or 71% of adolescents, and 4.5 million have received a booster dose, or 29% of adolescents with the primary series. Next slide. So then this slide puts the vaccine coverage for the pediatric ages in context for other age groups, for at least one dose in dark blue, and booster doses in the eligible population in light blue. The pediatric population is highlighted on the box on the left. You can see that the overall vaccine coverage is the lowest among these pediatric age groups. Next slide. So now we'll walk through the overall vaccine recommendations. As a reminder for today, we aren't discussing any new policy for COVID-19 vaccines. These slides are summarizing the existing recommendations that have been discussed at previous meetings. Overall, people ages 6 months and over are recommended to receive a primary series of any age-appropriate, FDA-approved or FDA-authorized monovalent COVID-19 vaccine. Then people ages 5 years and over are recommended to receive one bivalent mRNA booster dose after completion of any FDA-approved or FDA-authorized monovalent primary series or previously received monovalent booster doses. Then with the recent updates, as a note, the monovalent mRNA vaccines are no longer authorized as booster doses. And as we mentioned earlier today, Novavax is now allowed in some populations for a booster dose as well. Next slide. Homologous or the same and heterologous or mix and match booster doses are allowed. There's no preference provided the vaccine age is appropriate. So on that note, people who are age 5, for children who are 5 years of age only the Pfizer bivalent booster is authorized. But then for everyone 6 and over, both Pfizer and Moderna bivalent booster doses are options. Next slide. So now we'll just go over the more detailed schedule for children and adolescents who are not moderate to severely immunocompromised. Next slide. So for children ages 6 months through 4 years, they're recommended to receive either a 2-dose Moderna primary series, separated by 4 to 8 weeks, or a 3-dose Pfizer-BioNTech primary series, where dose 1 and 2 are separated by 3 to 8 weeks, and dose 2 and 3 are separated by at least 8 weeks. Next slide. Children ages 5 through 11 years are recommended to receive either a 2-dose Moderna or Pfizer-BioNTech primary dose, doses separated by 4 to 8 weeks if Moderna and 3 to 8 weeks if Pfizer. And a bivalent booster dose is recommended at least 2 months after completion of the primary series or the last monovalent booster given. Again, for those who are 5 years only a Pfizer booster can be given, but for those 6 through 11, either Pfizer or Moderna can be given. Next slide. Then adolescents 12 through 17 years are recommended to receive a 2-dose primary series of either Moderna, Pfizer, or Novavax. The primary series is separated by 4 to 8 weeks if Moderna and 3 to 8 weeks if Novavax or Pfizer. Regardless of the primary series, either Pfizer or Moderna bivalent booster is recommended at least 2 months after completion of the primary series or the last monovalent booster. Next slide. So now we'll walk through the vaccine schedule for children and adolescents who are moderate to severely immunocompromised. Next slide. For children ages 6 months through 4 years, they're recommended to receive a 3-dose Moderna primary series, where dose 1 and 2 are separated by 4 weeks, dose 2 and 3 are separated by at least 4 weeks, or a 3-dose Pfizer-BioNTech primary series, where dose 1 and 2 are separated by 3 weeks, and dose 2 and 3 by at least 8 weeks. Next slide. Then children 5 through 11 years are recommended to receive a 3-dose Moderna or Pfizer primary series. Dose 1 and 2 are separated by 3 weeks of receiving Pfizer or 4 weeks for Moderna. And then dose 2 and 3 are separated by at least 4 weeks for both. Then the bivalent boosters recommendations are the same for non-immunocompromised children, where a bivalent booster is recommended at least 2 months. And again, and for age 5, it's only Pfizer. Next slide. Then adolescents 12 through 17 are recommended to receive either a 3-dose Moderna or Pfizer primary series, dose 1 and dose 2, again, separated by 3 weeks of Pfizer, 4 weeks for Moderna, and dose 2 and 3 are separated by at least 4 weeks, or the 2-dose Novavax primary series, separated by 3 weeks. Then again, a bivalent booster is recommended at least 2 months after completion of the primary series or prior monovalent booster dose. Next slide. Then we do want to highlight that there is some complexity for the pediatric COVID-19 vaccines. This includes vials, labels, and cap colors, but it also includes that the primary series are monovalent and the boosters are bivalent currently, and that the doses and intervals vary by both age group and vaccine. This is just to highlight the need for continued work to streamline the COVID program and to support frontline vaccine providers who are doing the monumental effort to vaccinate children and adolescents. Next slide. So in summary, COVID-19 vaccination is the single best way to protect people from serious COVID-19 illness. COVID-19 vaccines continue to be effective in reducing the risk of severe disease, hospitalization, and death, including against the currently circulating Omicron variants. However, we know that many children haven't yet initiated a COVID-19 vaccine primary series. So we have continued work to do so all eligible children are able to get vaccinated. Then we know that the benefits of COVID-19 vaccination outweigh the known and potential risks, including the very small risk of myocarditis or pericarditis. Next slide. So overall, over 30 million children and adolescents have received at least one COVID-19 vaccine dose. And while that's great progress, there is still much work to do to increase coverage among children. As we'll be discussing today and tomorrow, incorporation of the COVID-19 vaccines in the immunization schedule in the Vaccines for Children, or VFC program, is an important step towards inclusion of COVID-19 vaccines in a routine vaccination program. We'll hear more about the VFC vote next, but I want to highlight that the details of the implementation for the COVID-19 vaccine VFC program will require ongoing work, but the ACIP vote allows the progress to begin. So it's not the finish line, it's the start line. And then we'll hear more from Dr. Santoli about VFC next, but I just want to highlight that the point of the VFC vote is to allow for or underinsured children to have access to COVID-19 vaccines at a time in the future for when the vaccine transitions to a commercial market. We know that both now and in the future, equitable access to COVID-19 vaccines for all ages and populations remains critically important. Again, this includes now, while the vaccines are being supplied by the federal government, and in the future, when we one day move to a commercial program. Next slide. Then typically I'm having to end where we immediately toss to an ACIP discussion, so I'm not always able to appropriately acknowledge everyone, but I just want to very much thank the variety of people. So there is a Corvid and other respiratory virus proposed division that does the lion's share of COVID work at CDC, then an immunization services division, then the immunization safety office that we're always indebted to. Then specifically, I want to call out a small but mighty vaccine policy team. So Evelyn Twentyman is co-lead. Megan Wallace has been our data lead and has done all the ton of the amazing benefit risk analyses and the grade. Monica Godfrey has done a lot of our ETR work. You guys just heard the great work from Catherine Fleming-Dutra, who's done a lot of our pregnancy and infant work. Hannah Rosenblum has been fantastic for immunocompromised populations. Danny and Lauren have been on our data team. Tamara and Ruth are our fantastic VE people. Alicia Hall is the clinical guideline. She's the one that actually does most of the fantastic, beautiful slides that outline everything. Mary and Sue are on her team as well and do a monumental amount of work. Then Joellen Willicke does all the clinical education material, along with Lauren, Alex, Sarah, and Sierra keeps us all in line. So anyway, I don't often get to kind of acknowledge when we're moving really quickly, but I just wanted to extend my heartfelt personal thanks to this fantastic team that helps us get through what has, again, been on average about one ACIP meeting a month for the last 2 to 3 years. Thanks.
Thank you so much, Dr. Oliver, and also want to extend our thanks to your entire team. That seems to keep growing as the number of decisions have multiplied. So we'll open this presentation for questions, and then I just want to acknowledge that we're going to go to Dr. Santoli after this. Dr. Cotton.
Thanks a lot for all the excellent presentations. I had a question about children who are over the age of 12 who are getting basically full dose vaccines. And for the immunocompromised, they're supposed to get usually 3 doses of mRNA in the primary series, but it's recently come to my attention that many pharmacies no longer have monovalent mRNA vaccine, or at least some of them in my region have shipped monovalent vaccine back. So then what would the recommendation be in order to give them a full primary series if monovalent isn't available and if only bivalent vaccine is available?
Thanks, Dr. Cotton. So right now, the primary series is only authorized to be monovalent product, but we're aware that this kind of is emerging as an issue as we've transitioned to a lot of the bivalent supply. We are trying to work with a lot of the vaccine deliveries, both pharmacies and kind of health departments, to make sure that there aren't pockets where there's no monovalent vaccine. So I think we would say if you run into that in an issue, potentially contact the health department, or if it may not be at that local pharmacy, hopefully it's still at one in the area. But we are conveying to jurisdictions to please keep some supply of the monovalent on hand, because there's absolutely people who still need that for right now. But thanks.
Thank you.
Dr. Long.
In a related question, I know there are a lot of strategies being considered for the next generation of vaccines, but is there an anticipated that there will be a bivalent primary series? Because although, there are fewer adults getting immunized initially, all the children are. So it would seem it would be way better if we could get the right dosing and a bivalent. That would be very beneficial. Do we know anything about that or a timeline?
Thanks. I don't have a specific timeline, but I know that studies are ongoing. And so we look forward to a time when we can hopefully bring that data and have those discussions. So it is on the list of things that we're continuing to talk about. And as soon as we have data available, we'll absolutely bring it. Thanks.
Thank you. I'd also like to just emphasize that point. So according to the slides, we just barely have 5% of children under the age of 5 or under who have received their primary series, which means we have an opportunity with 95% to be able to provide them a potential bivalent primary series. So, my hope is that will continue to get prioritized, because it is a great opportunity. That opportunity is now, passed for most adults. Any other questions? Dr. Long.
I guess just another statement, as we said before, Omicron has changed the landscape for pediatrics, for pediatric hospitalizations, for pediatric deaths. And unfortunately, for some reason, the safety issue in the very young ones came up and got a lot of legs from misinformation that has, I think, made people think they'll just wait and see for their children. They'll take the risk for themselves, but they won't take the risk for the small children. We have to get the message out that it is not, just the saving of a couple of days of a cold, but that this is a serious illness in children, and that there's a vaccine that's available and they should have it.
Thank you, Dr. Long. Dr. Daly?
Yeah, I do want to discuss this point a little further. So I've been tremendously worried about the complexity of the program, including at the primary care and immunization clinic delivery site. And even though I'm actively in the work group, it's hard for me to know kind of what the time frame is for that. And I think we need to work closely with the FDA and with the vaccine manufacturers to really sort of say, in order for us to improve and simplify the schedule, what needs primary data in a clinical trial versus what can be inferred? I will, bring up a number of examples. So this is not just simply we just need more education of frontline providers. That actually is in my mind, the wrong answer, even though that's part of the solution. It's really about, is there a way not to have a special row in every table for 5-year-olds? Okay, and does there need to be a clinical trial to do that or not? That's more minor in a way than this issue about, are we moving towards bivalent primary series? And then where are those studies and when are they going to be done? I think we need to be explicit about what needs clinical trial data, and then who's doing those studies, and when are they going to get to the FDA for review, and then when do they get to this committee for deliberation? So I think we just need to keep pushing that point as much as we can. Thank you.
Thank you, Dr. Daly. I don't see any additional hands raised at the moment, so I'm going to take the opportunity to turn it over to Dr. Jeannie Santoli to provide a presentation on VFC.
Hi there. I actually have two little stats I wanted to share with you all as we get started with this. On November 2nd, 2021, CDC endorsed the recommendation for the vaccination of children aged 5 to 11. This was the first pediatric vaccination for younger children for COVID, and we are now 351 days since that event, so we're actually just less than a year. And then on June 21st, 2022, there was a rollout of COVID-19 vaccine for children less than 5 to 6 years of age, and that's been 120 days today. So the world is moving at lightning speed because of your work. So I just want to say that before the resolution and get started. This is all going to look very familiar to you all. Next slide, please. So the purpose of this resolution is to add vaccines for the prevention of COVID-19 to the VFC program. Next slide. The eligible groups are all children aged 6 months through 18 years. Next slide. The recommended schedule, dosage, and intervals. COVID-19 vaccines are either authorized under emergency use authorization or approved under a biologics license application, are to be administered according to the most recent age and vaccine appropriate schedule included in CDC's interim clinical considerations for COVID-19 vaccines, with a link. Next slide. The recommended dosage, there's a referral to the FDA page where the fact sheets are listed, and the contraindications and precautions are available in CDC's interim clinical considerations for COVID-19 vaccines with the same link. Next slide. So I wanted to add this, and this really just underscores what Sarah explained earlier, because it seems very important to make sure that everyone is aware of what this VFC resolution is for and how it's timed a little bit differently than VFC resolutions usually are. So COVID-19 vaccines will not be available through the VFC program immediately following the passage of this resolution, because they remain available for all Americans under the national COVID-19 response. But following the passage of this resolution, we will begin some additional necessary steps to awarding contracts for COVID-19 vaccines. And then once the vaccines are commercialized and therefore no longer available under our national COVID-19 response, then VFC providers will be able to order vaccines through the VFC program. And the timeline for commercialization of COVID-19 vaccines in the U.S. has not been finalized. And that concludes my presentation.
Thank you, Dr. Santilli. Are there any questions for Dr. Santilli? We will have to move to some vote language, but I just want to make sure we can add any clarifications or questions. Dr. Romero?
I just wanted to make sure that everyone understood that this is not a policy change, nor is it a mandate for the use of the vaccine. It is a way to ensure access to this vaccine for those individuals, those children that don't have insurance. So I really wanted to make that clear. Thank you.
Thank you, Dr. Romero. Dr. Cotton.
I'm not a pediatrician. Are there vaccines that are currently recommended for children that are not covered by the VFC? People are shaking their head no. So, so just to clarify, any vaccine that is recommended by the ACIP is covered?
A clarification on that? Oh, I'm sorry. Go ahead, Melinda. I didn't see you.
Travel vaccines are not routinely included in the Vaccines for Children program. So there was a vote to include, ACIP recently voted for the cholera vaccine for children who were traveling to areas with active cholera transmission. And we did not have a VFC vote for that.
And can I just ask Dr. Romero to just clarify that again, that it would not be a mandate, this would not be something that because it's covered by the VFC that schools would mandate, it would not be, Can you just elaborate a little bit on that to help us out?
Right. So again, let me state the second part of what I said, which is this is an access issue. This is an issue to allow children that don't have insurance to gain access to this vaccine. It's particularly important as we move on to commercialization of the vaccine. It is not listing this as a routine vaccine for children to enter school. Okay? And it is not a change in our policy for these vaccines, for these routine vaccines in children.
CDC does not make
Right. And as Dr. Cohen is telling me, and again, reminding me, which you should all know, is that CDC doesn't make state recommendations for vaccination, right? That is a state issue about what vaccines are required for school attendance, right? So that's another issue totally separate from this.
Thank you very much for the clarification.
I see Ms. McNally. You have your hand raised.
Yes, thank you. I am thinking about the countermeasures injury compensation program versus the vaccine injury compensation program. Does the availability through VFC render this a covered vaccine now, or is it still a covered countermeasure? Thank you.
So the VFC vote does not impact inclusion in the countermeasures injury compensation program. There's specific steps that have to be followed for a vaccine to be added to the vaccine injury compensation program, and inclusion in VFC is not part of that process.
Thank you, Dr. Wharton.
Thank you, Dr. Wharton. Dr. Hoag?
Thank you, Dr. Lee. One quick question and then one comment. I'll ask the question first. Do we have a rough idea of when most of the monovalent pediatric approved vaccine that's currently available in the marketplace will expire? Uptake has slowed. We obviously saw that we need to see that uptake increase and improve for primary immunization, but do we have any idea when that's going to expire? And would that give us any insights into when the commercial program might need to be starting, because the manufacturers are going to have some incentive to produce primary series vaccine? So that's my first question, then I'll have a comment.
Hi, this is Sarah Meyer from the Immunization Services Division. So we do know that a large proportion of our monovalent mRNA vaccine stock would be expected to expire over the next couple of months. However, there are some unknowns here, like we mentioned, the unknowns about the availability of bivalent mRNA vaccines for primary series, whether these expiration dates could be extended, and just several things that are currently unknown, but that we expect to be able to work through in the next couple of months. So right now, as was mentioned earlier, we do still have sufficient supply of the monovalent mRNA vaccines. As Dr. Cotton brought up, we are aware that in some locations people are having less and less of that, but the vast majority of people in this country still live within 5 miles of a site that carries the mRNA vaccine. So over the next couple months, we will continue to work through these issues, but appreciate you bringing them up. Thanks.
And then my comment is that as the COVID vaccines for children and adolescents move to the commercial market, one concern that I have is that, especially as COVID vaccines became available early on for adolescents 12 years of age and older, many of those doses were given in pharmacies. And historically, in most states, pharmacies are not approved as VFC providers. I think there's less than 150 or something like that VFC providers that are pharmacies around the country. And I think from a policy standpoint, CDC and the state departments of health really need to take a careful look at that going forward. I am concerned about adolescent patients in particular perhaps not getting immunized. And I think pharmacies do offer a good option for getting vaccinated, and the pharmacists can advocate with the patient and with the parent for their need for a primary care wellness visit from a primary care provider at the time they give that immunization. So I just ask that that be considered or thought about and perhaps actively discussed going forward.
Thank you, Dr. Hoag. We'll move on to Dr. Duchin.
Thank you, Dr. Lee. Can I make a comment about the VFC program?
Please go ahead.
Thank you. I would like to remind folks that in June 2021, the National Vaccine Advisory Committee produced a report with recommendations for advancing immunization equity. And that report recognizes that immunization equity is a longstanding and persistent barrier. Inequity is a longstanding and persistent barrier to immunization uptake for almost all of our recommended vaccines. And underlying systemic barriers and biases in the immunization system exist, and they need to be removed to create a truly optimal health for all system. A recent publication in Health Affairs reminds us that since its enactment, the Vaccine for Children's program has lifted immunization rates across all children, significantly reducing financial and racial inequities in childhood immunization rates. And its successes have been measured not only in healthcare access, but in health outcomes. It prevents or has prevented millions of cases of serious diseases, including hospitalizations and deaths. And net savings to insurers have been estimated in the billions of dollars, and societal savings from the reduced impact of preventable disease in the trillions of dollars. Yet our Black and Hispanic and Asian community members who are adults have lower vaccination rates than whites for all recommended adult vaccines. For example, adults with health insurance have vaccination rates 2 to 5 times higher than people without health insurance for influenza, shingles, HPV, and other diseases. So with respect to today's discussion about the VFC program for COVID-19 vaccines, I wanted to highlight the NVAC recommendation that we really need a Vaccines for All program, children and adults. A Vaccines for All program should be created and operated in parallel with the VFC program that could provide vaccines at no cost to the recipient, regardless of their age, so that financial barriers to both COVID-19 vaccines and all other ACIP recommended routine vaccines are removed. Thank you for the opportunity to comment.
Thank you very much, Dr. Duchin. Dr. Lear.
I would like to strongly second that recommendation. It is a wonderful idea.
Thank you, Dr. Lear. Thank you so much. And I think we will now move on to putting up the vote language for the VFC resolution. Okay, this one I might be able to read, Dr. Santilli, but I will turn it over to you.
So the vote is approve the vaccines for children resolution for COVID-19 vaccines.
Thank you. Simple and straightforward. Any questions? Dr. Long.
I'm just bringing to your attention, the agenda says this follows the public comment. Is it?
We have to put the motion on the table, and then we go to public comment, and then we will vote.
I'm sorry.
Yeah. Dr. Paley?
I wanted to make a motion to accept this.
And I'll
Thank you, Dr. Paley. It's been moved. Would anyone like to second? Ms. Bata?
Second.
I second that.
Thank you, Ms. Bata. So it's been moved and seconded that we accept the vote language that is put on the slide in front of us. So we will now move that to the vote section. But at this moment, I believe we are actually running on time. This is a miracle. And COVID-19 actually got us back on time. So we will take a 15-minute break and plan to reconvene at 3:30 for public comment. I want to thank all of our speakers. That was a really helpful and informative session. Thank you, everyone.